1,000 patients, demonstrating a mortality rate around 0.6%. And if you just want to take the mortality of an appendectomy, that range is around 0.5%. So it was felt that what we have been seeing actually in Orator 2 was sort of like an incidental event, which should not make us stop doing these types of operations and bleedings. That was looked at by the people from Pittsburgh. That's in the range of 2.6% across the board. And as a consequence, once again, wasn't felt that this one single case leading to the termination of Orator 2 should, prompt us to shy away from this type of intervention. That's, I think, what we can say about Orator 2.
All right. I think in the interest of time and to discuss this very intriguing and timely topic further, we have to go to the breakout room, and I might encourage all of the participants to think of questions and type them as they arise so that we can try to get them answered for all of us. Christian, see you in the breakout room.
Thank you.
All right, thank you. So now we would like to proceed with our 14 of the 48 hours of otolaryngology updates webinar. We will be joined with Christian Beetz, with Mark Pretorius, and now with our next speaker, Mr. Hesham Saleh. We are now sharing his presentation.
Dear friends, dear colleagues, good morning or good afternoon or good evening, wherever you are in the world. I'm very grateful for the invitation for this very, very interesting meeting. I am going to talk about Alar-based reduction simplified today. I'd like to make things easier for myself, and I hope I can come up with a lecture that makes it easier for you as well. I have no conflicts of interest in this talk. Please don't take photographs of the patients. As we talk about rhinoplasty all over the world, I'm showing you a breakdown of the patients that I see. So you can see that I see a mix of patients because I work and live in London, and we have a very mixed population. So 41% of my patients are Caucasian, 20% are Middle Eastern, 17% are Asian from Indian, Pakistani, Bangladeshi background, and only 1% from the Far East. I have a lot of Mediterranean patients, 14%, Afro-Caribbean less, 2%, and Latin American 2%, and mixed 4%. I showed this because we know that certain ethnicities will have wider Alar bases, and it's probably commoner that we need to do Alar-based reduction in them. It doesn't always apply, of course, but this is an example of my patients. When you want to do Alar-based reduction, you really have to analyze it systematically and step by step to start with. What is the Alar base? What's the width of the Alar base? We say that traditionally the width or intercanthal width is equivalent to the alar base width or the interalar width, because the interalar width is the area of the insertion of the alar fissure groove here. But then there's the alar flare. The alar flare is that width, the maximum width of the convexity here on the alar edge, which is always a bit larger than this interalar width. So we're talking about interalar width when we measure or compare it to the intercanthal width, not the alar flare itself. That's number one. When you do Alar-based reduction, what are the indications of Alar-based reduction? It could be either because of primary Alar flaring or plus minus width. So you can do it for flaring only, width only, or for both together. Occasionally, when we have done a deep projection, especially if it's quite an extensive deep projection, the alar base widens. So this is a secondary indication as well. It's a secondary to tip deep projection. Now let's analyze the alar base. Preoperatively, this is what I do. I look at these basal photographs. And first I look at the interalar length, how long it is. That would give me an idea of the shape of the alar vestibule itself. And then the external alar length as well, comparing to the internal alar length. And then I look at the nostril sill width. I think this is really, really important because that will show you how much alar width is there. So nostril sill width. And then I look at the shape of the nostril itself. The shape of the nostril could be oval or round and so on, depending on ethnicity and the alar width itself. So I record this in my notes as well. And then the shape and width of columella. Many patients, when you do alar base reduction, will have wide columella. So you have to be careful with this because it can narrow things too much, and often you have to narrow the columella. So it's very important to see the columella shape and width. So this is the summary of my talk, or really the techniques I would use, or I make it simplified by using this. Is traditional description from Gene Tali, which is used all over the world, and I find it really applicable to my patient and my practice. So I divide the operative technique into 3. So only the nostril sill excision, this is here number 1, or alar wedge excision, or combined. So this is in the majority of cases what I'm doing. So the nostril sill excision is done for reduction of the alar width only, so just this distance. So you just excise from the sill. The alar wedge excision is done for the alar flare only, which is more common than the alar width only. So that's the wedge from the skin where the flare is to decrease the flare. Combine is commonly done as well. It's for both alar flare and alar width excision. So you take a wedge, but also you go all the way into the cell and excise from the cell itself. So these are the 3 main techniques I use in alar base reduction. So what's the operative technique? I tend to mark the skin. I think it's very important because you want to avoid asymmetry. So basically you mark the skin, and I use a caliper. A caliper makes it easier to mark because you can actually exactly measure in various angles or various dimensions. We use a caliper to mark the skin. And then I infiltrate with lignocaine 2% and adrenaline or epinephrine 1 in 80,000. This is the standard injection is available in the UK. So I infiltrate with this. And then I'll excise the skin in a wedge-shaped according to what I'm doing, or a whole of the combine or the cell only. And then I'll stitch the subcutaneous tissue with just 140 Vicar repeat with a buried knot, that just to approximate these deep tissues or subcutaneous tissues together. And then I close the skin. For many years now, I've been closing the skin using 60 Vicar repeat, which is obviously absorbable. And I've started this probably more than 12 years ago, using the columella with the open approach. And I studied the scars and found the scars quite good, comparable to using nylon or Prolene. And then I started using it later on in the alar base as well. I've used it for many years now. We published this some years ago. So this is something that I like to talk about a lot in my meetings or my talks about the alar base. I was traditionally taught in my training time that to make the incision 2 millimeter anterior to the alar facial crease here, because the scar is better. But then you'll see that a lot of people talking about making the incision in the alar facial crease itself. So would you do it 2 millimeter anterior to it or in the alar facial crease? So in my experience, 2 millimeter from the alar crease is very well camouflaged in fair skin patients, and it heals very well. And in a few months, you don't see it anymore. But in darker skin patients, if you make a 2 millimeter anterior to the alar crease, you will see it. It doesn't go away, and it is obvious for many, many years, and you will see it. So an incision in the alar crease is probably better camouflage in darker skin patients. I'll show some examples. This gentleman here is having a combined technique, alar base reduction for the alar wedge and the sill to decrease the alar flare and the alar width. As you can see, I'm starting medial lateral, and this is that wedge, plus I'm going all the way to the sill, removing a tapered or a wedge-shaped combined skin and subcutaneous tissue. It's being prepared. Obviously, I marked it, as you can see. I've measured it before that. It's being prepared with the infiltration, adrenaline, and lignocaine. Very precisely cutting into the deeper tissue. I'm always checking where I'm going. And obviously, you can go further if you feel you've cut enough, but the best is to cut less than you think. If you think you're cutting too much, is not a good idea. But most of the time, you've measured it, so you be precise and you get symmetry. Often after you've done that, so you can see now I am thinning the flap toward the final part of it. Often you get some bleeding here. You can use bipolar diathermy if you need. As you can see, it's a bit of blood here. Bipolar diathermy cauterize that vessel. And then I will use that 4-0 Vical repeat. Bury the knot to close the subcutaneous tissue. That will approximate the edges, strong enough to keep them together, and it also press on the vessel, and mostly it also helps to stop the bleeding if there's any. Just one suture, and the knot is buried, and that helps obviously to close, approximate the skin together, and to stop the bleeding. Finally, after that, make sure the edges are correctly positioned, and the first is that suture at the edge of the sill. That is the most important, because you need to get this right. If you don't get this right, it will be obvious with a sharp edge. You get that correctly, and then you can follow with the other sutures. This is a 6-0 Vical repeat I've talked about before, and I don't remove them. They tend to fall off. I can trim them, but I make them short anyway. But they tend to fall off in a week or so. So first suture looks fine, then I could continue with the rest. And that's it after closure. And you can see, let's go back a bit here. You can see the end result with both sides done. So that is the procedure. Now let's see some cases and some variety of these techniques. So primary alar flaring plus minus width. Let's see that first. So here is a patient with some width. She doesn't have much flaring. She just has wide sill here. So we just do a sill excision, nostril sill excision. And here it is. 6 months later, still see the scar a little bit, but the excision was done here. So we narrowed that sill. Obviously, we narrowed the tip at the same time. So that is the sill excision. To be honest, I find, like in my cases, I do less numbers of the pure sill excision in contrast to the combined technique or also the alar wedge excision. So it seems to be commoner in my population. Here's another patient with some alar flare as well, and you can see it's a bit more on the left and the right. She's from a Russian descent and had alar wedge excision. So this is just a wedge excision for the alar flare. Looks a bit asymmetric initially here, But later on, it's healing. 6 months, 12 months, looks more symmetric. And you can actually barely see the scar now. This is a fair skin patient, and I did the excision at 2 millimeter anterior to the alar crease. That was some time ago. I started later on doing the excision in the alar crease itself. So I did the incision in the alar crease. Most patients, even fair skin patient, I find it easier and heal quicker and doesn't scar as well. So this patient already had previous alar base reduction. You can see here, but she still has a very extensive flaring. So she'll need alar wedge excision. So just on a wedge excision as such, just from here and here. And early in 2 months, you can still see the scars here, but we straightened that alar flare. Looks better here. And that's 12 months later, and you can barely see the scars. So they healed very well as well. Now, let's see a bit more severe alar width, alar-based width here. This is a patient with asymmetric tip as well, and needed reduction of the alar flare mainly. She does not want to have, you can see she's dark skinned. She doesn't want to have a very narrow alar base. So we just did a wedge excision, plus obviously refining the tip. And here she is from the basal view 12 months later, and you can't see it's scarring that much. So she had just the wedge excision to narrow that flaring, to get rid of the flaring here. Obviously, the tip was narrowed as well through an open approach. That's how. 12 months later, and you can't see the scar that much. Now, this is a patient, secondary rhinoplasty, who has the combination of alar flare and alar width. So here we come to the combined techniques now. So often I see a patient like this. Interestingly, this patient is a mixed race anyway, so she's got quite a wide alar base, and she had the combination, a combined technique of alar wedge excision and nostocyst excision, and that's her a year later. And if we look from the basal view, still tiny bit of the scar here because we've done the sill, tiny, but it's not very obvious. So the patient's happy with this. So that's combined technique, which often need for patients like this, wide alar base plus alar flaring. Another patient with thick skin and quite a wide alar base, and also amorphous tip here, shows from Asian background, and needed combined technique for reduction of this alar width and alar flaring. Here is a superior view, and here is a quarter views, and this is the lateral views. She needed a bit of projection as well, slight projection of the tip. So that's her. It's probably about 8 months later, and we refined the tip and we reduced the alar base by combined technique, alar SIR and wedge reduction as well. And here we are from the basal view, so you can see we have reduced the width here by the sill excision, also the flaring by the wedge excision. And you can barely see the scar. It's not even a year yet. It's healed very well. That's a superior view. Quarter view. Quarter view. That's reviews. Then the second indication for alar base reduction is secondary to tip deep projection. So every now and then, you'll have a patient with extreme overprojection, and you always have to consent them prior to the surgery for deep projection if you're planning to deep project that tip. And I tend to do that, and I'll tell them it's very likely I have to do a deep project, alar base reduction after deep projection, and if they're happy with that, we'll go ahead. Very occasionally, you'll find the patient say no if you do it in the second stage, and often you could do that; it's not a problem. The reason is obviously when you deproject the tip, it's like it's a pressing on a tip of the pyramid or a tent, and the base widens, And this is what happens. You get flaring, and you often get width as well. So you probably, most of the time, have to use the combined techniques. I'm going to show you an interesting case here, because this patient is a secondary rhinoplasty. She had rhinoplasty years ago. You see probably from the frontal view, it's almost like an inverted view with prominent of cartilage here. And you see this alar retraction, but you will see in the lateral view, she's quite over-projected. She has some alar retraction as well, and some irregularity in the dorsum here. But that's an extreme over-projection. So she needs deprojection. When you deproject this, you know that you probably will need alar-based reduction. So this lady had this done. So she had an endonasal approach, actually, with a tip delivery and refining, plus reduction of the dorsum and osteotomies. But to deproject that tip, we had to have lateral crural overlap. So lateral crural overlap to deproject the tip and rotate it a little bit. In addition to that, she had other techniques such as this alar rim grafting for the alar retraction and so on, and combined technique for alar-based reduction, sill and wedge resection. This is not her, as somebody else's photo, but this is when I do this lateral crural overlap endonasally. I tend to do it anterior part of the segment of the lateral cross. It overlaps the posterior part. So this is the lady here later on, 12 months later, when she had the deprojection, refining the tip, plus the alar-based reduction. And you can see the difference from that basal view. The combined technique is done. You see it in the lateral view, the deprojection, alar, obviously alar rim graft here, mainly the alar-based reduction as well. And here is the frontal view. So in conclusion, alar-based reduction is really very effective technique, and it's to see how much difference it makes to certain groups of patients, obviously. And I think it really can be simplified into these three categories. You very rarely find you actually go outside these categories, and the majority of my patients I just use them. I think the most important thing is, though, to have a meticulous technique with measuring and using caliper like I showed, because it's essential to avoid asymmetries. Asymmetries would be obvious and the patient wouldn't like them. And also, as I showed you, I do the incision into the alar facial crease, and I think it's better with the scarring. Thank you very much. I hope see you again in another meeting in the near future.
Thank you very much, Professor Hesham Saleh, head and professor of rhinology, facial plastic surgery at the Imperial College in London, England. He is board certified in facial plastic surgery and is the immediate past president of the European Academy of Facial Plastic Surgery and past president of the British Society of Facial Plastic Surgery. Thank you very much and welcome. We're glad you joined us. And now we would like to proceed with the Q&A.
Thank you very much. Saleh, thank you very much for this intense talk about a very, very specific issue that is of great importance, I assume, for the shape and appearance of the nose later on. So is this, it all probably has to be considered right away, but is this always in the first surgery that you perform, or is it more or less something that you refine, especially when another rhinoplasty has already been taken place?
Yeah, thank you for the question. Many times it is different. In the first procedure, when the patient present, they actually ask specifically about it sometimes, and if the measurements are correct, we do it in the first procedure. But sometimes, as I showed, it's secondary to deprojection of the tip, and then you do it as a secondary procedure. And I get often patients referred to me who had surgery already and had some alar-based reduction, but they feel it's insufficient. So I have a lot of secondary ones as well. So it's a variety, but I think the majority are primary. as a first operation. Yeah.
All right. Has this also functional effects besides the aesthetic ones?
I don't think so, unless you excise too much, because obviously it is in the area of external valve, but it doesn't affect the valve directly because it's too caudal for that. Unless you really take too much of the cell and too much of the wedge here, and you narrow to a degree that it looks unaesthetic anyway, then you would not cause any problem with the nasal valve. So it's really unlikely.
Okay. And the question is, does vicryl suture cause more skin reaction than the nylon thread?
So this is a very good question, an interesting thing, because for many years now I've looked into this. So maybe about 12 years ago, I did a small study when we compared vicryl repeat 60 for the columellar scar, and we looked blindly. We had 2 blind observers who looked at patients who had either, and it was exactly the same. There was no difference in the scar. So the answer is no. It's not better and it's not worse, but it's easier for the patient because you don't have to remove the sutures. And we all know sometimes when the patient comes to for the clinic after a week from the operation to remove these, they say this is the most painful part of the procedure because the columella is very sensitive. So if you spare the patient that, it's the best. And I've used that now for many, many years, maybe 12 years, maybe longer, in the columella, and then after that in the alar base. And I think the scar always looked fine. It's not it's not worse than when I used to use nylon. It's just the same. So I continue to use. Yeah.
Okay. So then is it possible that you stage the alar base reduction, for example, postpone it for about 3 months or so?
Yeah, you can easily postpone it, because if you're not sure, because if the nose is still healing and is not really definitive appearance that you could see on the operating table, you can, because you can do it under local anesthetic. This is one of the advantages of this procedure, in contrast to a full rhinoplasty, that it's very easy to use local anesthetic in the alar base and to make it completely numb, and the patient will tolerate it really well, because it doesn't involve working into the nasal cavity or the septum. Because the problem when you do a full septal rhinoplasty under sedation or local anesthetic is the bleeding within the nasal cavity that the patient will have to tolerate and to set them up and so on. But this is outside the nasal cavity, just in the skin. So you could easily do it under local. So it could definitely be postponed and done later if you're not definite about how much you need to do. Or if the patient doesn't want it done to be at the same time anyway. It is possible.
Right. How long did it take you to get that the incision is best made not in the fold itself, but a little bit distant from that?
Yes, after a few years of looking at my patients with dark skin, because I have so many patients from different countries because I'm in London, and I discovered that the scar shows in patients with dark skin in many of them. And I realized, looking back at the literature, it actually described mostly in patients with very light skin. So I maybe about 4 years later on, I changed into the alar wedge, into the alar groove itself.
All right. Another question here is the symmetry achieved at the end of the procedure? Are the patients satisfied or are they not?
Yeah, so symmetry is very important. And sometimes I have done the procedure and it looked still asymmetric. So I go back, patient still sleep, I take some more. So I do my best to achieve symmetry. But I showed one patient here, when she was like 3 months after the operation, it looks like more than the left, bigger than the right. Even that, I did it on the table, looked exactly correct. That was swelling. So you have to reassure the patient. You have to explain to them pre-operation. I always do it with a consent, that we do our best to get symmetry on the operating table, but sometimes with the healing, there are variations can occur over the next few months, sometimes from swelling, sometimes from healing and scar retraction. So it's still possible to get slight asymmetry, even if you achieve symmetry on the table. It's very rare that I've had to revise them because of asymmetry, because if it happens, it's very minimal. It's not very obvious. So the patient is usually happy.
Okay. Did you ever have to basically widen the Alar base on a patient?
Yes, that's a very good question. Twice, not my patients. So I had patients, as I said earlier, if you excise too much, you can affect the function and everything. Seen patients, you will see them in Instagram. The people excise too much of the alar skin here, so they create straight line there. So that doesn't look natural and can affect the breathing as well. So for this, I have been referred patient, but only twice, and I've put composite grafts, composite skin and ear cartilage from the area just below the antihelix, and I use it successfully for that. You can never make it as natural as it was before, but can improve it. So I have done that, and that widens the alar base.
Okay. And do you use the bipolar for bleeding always? Is it dangerous for scar building?
No, because I use it in the subcutaneous tissue, not in near the skin. So if there's no bleeding, I wouldn't use it. But sometimes you get this small artery that bleeds, and I use just a bipolar once, and it'll control it. And that's deep subcutaneous tissue, so it's away from the scar. It wouldn't affect it at all.
Okay, so thank you. If you have additional questions for our speakers, please follow them into our separate lobby Zoom. The link is provided in the chat. And now we're very happy to welcome Mr. Markus Hess. He is professor of otolaryngology and phoniatry, subspecializing in laryngology, phonosurgery, and disorders of professional voice users. In his multidisciplinary medical voice center in Hamburg, Germany, one of his major focuses is office-based laryngological interventions, such as botulinum toxin injections in patients with spasmodic dysphonia. Thanks for joining us.
My talk today is about spasmodic dysphonia and new injection techniques. In this talk, I first want to introduce where I'm working. I'm working at a voice clinic. It is a multidisciplinary clinic where we do diagnostics and therapy. And one of the therapies is office-based interventions. And today I will talk about injection techniques in the larynx and how we can do that from inside and from outside. Usually we know that therapy of spasmodic dysphonia adductor type is the injection of botulinum toxin into the vocalis muscle or the thyroarytenoid muscle. And usually it was done always percutaneous through the skin in a cricothyroid approach, as you can see here in this example. So from the outside with a needle attached to an EMG device, we can hear the sound of the needle and the muscle, and then we inject. That is fine, and that's the mainstay. I would say that's the gold standard worldwide. But is there any alternative that we have? Now, I would like to talk about something that is a new approach, which is the injection into the ventricular folds. Let's see that here in this example. So you can see with a flexible endoscope, a channeled endoscope, we can advance a catheter into the larynx and inject into the ventricular fold. So this is different. This is not only a different approach how to route your instrument into the larynx, but it's also different because we have a different target right now, which is the ventricular fold. And so this is an alternative to what we had before. But we can also inject into the vocal folds with this approach, as you can see in this example video on the right side. So we can inject both ventricular folds and vocal folds through the larynx with a flexible endoscope. And so, as you can see here on the left side, we have a couple of therapy regimens. Of course, we have the voice therapy in all patients. Then we have the injections into the vocal folds in the green on the left and the ventricular folds. There are other techniques as well that I want to mention, but I will not talk about today, which is myoneurectomy of the vocalis muscle and the vocal fold, and it's the titanium implant where you separate the vocal folds with a thyroplasty from outside. So, but let's go into the detail right now. My intention is to convince you that the injection into the ventricular fold is a great option and alternative to the injection of the vocal folds. Now let's go to some details what happened before. We know that the botulinum toxin in the muscle has an action. What does it do? Well, it actually relaxes and releases the tension and the force of the muscle. What happens is that when we inject the botulinum toxin, it takes action, usually takes 1 to 2 days before it acts. And on this graphic, you can see, let's see on the left side, the pressed voice that is here where the blue line is. And as soon as we inject botulinum toxin into the vocal fold, what happens is that the pressed voice releases and works out to be a breathy voice. The breathy voice then catches back the strength within 3 months, usually, and then the pressedness of the voice gets back. And then we have a good phase, which is here, the green line. And in that time, the patient has a nice voice without pressed character, like no kind of strained and strangled voice. And as soon as the voice gets more strained, strangled, and pressed, then there's the indication to put in the next botulinum toxin injection, which then again repeats the cycle. So we have this zigzag for a lifetime, probably. That happens if we inject into the vocal folds, because the vocal folds, as we know, are the source for the phonation. Now, there was a nice paper, 2016, released from Blake Simpson and colleagues, where they published on a series of patients where they injected botulinum toxin into the false vocal folds, the ventricular folds, in adductor spasmodic dysphonia. And the functional outcomes were very promising in many cases. So they looked at those patients and saw that there was an effect of the botulinum toxin that resulted in a good outcome of voice. And after that, many more laryngologists started to do that. We also started to do that very early after release of this publication, and now we inject botulinum toxin into the ventricular folds. Now, you can use any botulinum toxin A, but we started with a Dysport, but you can also do the same with the real Botox or other brands. When we use Dysport, and be reassured that you really have to take care of how much the units are per medication that you use. So let's say 15 to 20 units of Dysport is not the same like 50 to 20 units of the Botox, for instance. So I would say the factor is 4, which means 20 units of Dysport might be 5 units of Botox. But this is just a rough estimate. So we use that as a starter in our patients. So if a new patient comes with adductor spasmodic dysphonia and wants to have botulinum toxin treatment, and then we start with injections of the ventricular folds alone, and we spare the vocal folds. The idea behind that is that if it has an effect, then the pressedness of the voice goes away, but the patients are not breathy because of overaction of the botulinum toxin in the vocal folds. So how does that work? Let's see, this is for the injection, a single-use injection needle, and here it is shielded within the catheter, but if you activate it with the handpiece in the office, then you can advance the needle out, and then you can insert it into your target, which is the ventricular fold. What is nice with this technique is that you can use a 25 gauge needle, which is a small cannula, and it inserts into the tissue 5 millimeters, which is a very nice injection depth for this indication. But before we inject into the larynx, first we have to anesthetize. So how do we do that? Well, you can just spray the larynx with whatever means you think is appropriate. We like to do it with a catheter through the channeled endoscope. So this works as shown here. So we have a different catheter. This is not the botulinum toxin catheter. So this catheter is only for the lidocaine 4%, has no alcohol, and in the awake unsedated patient, we can drip the lidocaine into the larynx. We let the patient phonate, we let them throat clear, but just very softly. Let me imitate that, something like so the mucosa gets contact to the lidocaine, and what happens then is that after 1 to 2 cc, the larynx is totally anesthetized for 5 to 10 minutes. And for this, you need a helper, as is shown on this photo on the upper right. So the helper or the assistant takes action when the surgeon says, okay, needle in, needle out, or please inject the lidocaine. So this is a dual person intervention in the office. When we anesthetize the larynx, some colleagues ask, well, at which region can we do an intervention, and actually can we get and do something to every spot that we see? And the answer is yes. And I was taught many years ago, well, everything you can see in the hyperpharynx and in the larynx, everything you can visualize with the endoscope, you can also touch. And I would like to show you with these two videos on the left and onto the right side that this is possible. Let me cut down the sound a little bit. So every space that you can see can be touched, like on the left side, the area epiglottic folds. On the right side, we can go even to the posterior part of the larynx, which is the interarytenoid space. We can touch the inner surface of the arytenoids, and so every spot can be touched. Now, luckily, the ventricular folds are not very gag eliciting, which is nice for this kind of intervention. However, I must say that the vocal folds, because they don't have nerves, they don't elicit gag response as well. If there is a, let's say, hyper-gagging region for eliciting cough or gag response, it is more the posterior part of the larynx, of the endolarynx, which is in the area of the medial surfaces of the arytenoids. So this should convince you, if you've never done this before, yes, you can touch all the different regions if you anesthetize nicely. For the next video, I would like to show you the injection again into the ventricular folds. There are many ways how to approach them. And then the question is, how deep do I go in? Well, usually I go in 5 millimeters, as long as the cannula is. And then as soon as I am inside of the tissue, then the assistant is asked to inject whatever I think is the appropriate dose. The volume that we put in is something between 0.1 and 0.2 cc. I would not recommend to put in volumes like 0.3 or 0.4 because this is way too much. If you put in smaller volumes, which means more concentrated botulinum toxin, it is very hard to measure that and to inject that. So a very nice volume is 0.1 to 0.2, and then you can adjust the concentration of the botulinum toxin that is in the catheter. However, we can also, if we have a case of very severe adductor spasmodic dysphonia, also put in the botulinum toxin into the muscle of the vocal fold, which is the vocalis, or the thyroarytenoid muscle. As you can see here, there are different techniques how you can do that. You can go closer to the vocal fold with the tip of the endoscope, or you can also rotate the flexible endoscope to reach that area. Now, nobody really knows why the injection into the ventricular fold helps. There might be different theories. I'm sorry that I can't go into that in this short talk, but I want to show you the close proximity of the different muscles of the larynx. On the right side, you can see the LCA muscle, which is in close proximity to the TA muscle, which is the violet muscle, but the ventricular muscle is also in the posterior part of the larynx, and then it inserts pretty close to where the other two muscles are. So there might be a functional unit of these three muscles Nobody knows. But it could be that this is also an indication for the help. There might be an idea also that, well, maybe if you inject into the ventricular fold, then there's migration and infiltration of the botulinum toxin to the other muscles. Could be, however, what we saw in our patients is that they don't have the breathiness that they would get if you put in the botulinum toxin into the vocal folds. Now, let me show you here in this lady who permitted us to show her in this video. So this is the introduction of the catheter into the flexible endoscope. On the right upper side of the video, you can see that the larynx of the patient, and then we can insert the cannula. And let me show you, advance this a little bit quicker. So I will do the first injection into the right ventricular fold. Let me now run this tape. So I'm going closer to the ventricular fold here. You can see that I'm rotating the endoscope a little bit. With my right hand, I'm steering the four-way endoscope so that I can go up, down, left, right, and then I inject with the help of the assistant. Then I would like to show you that I rotate the endoscope 180 degrees, which means that I have a rotation of the image of the endoscopy, of course, which means that the anterior commissure now goes more to the right or even upper side of the endoscopy image. Then I advance the flexible endoscope closer to the ventricular fold, and I'm intending to do the second injection into the ventricular fold, which I'm doing right now, getting close to the target. The needle is out, then I give it a little bit of a thrust, and then it's spilled out a little bit, and then I do the injection into the ventricular fold, which is done, and that you can target and see and monitor with the ballooning and bulging of the mucosa. Depends on how much volume you inject. The third injection goes into the left vocal fold. This is for the demonstration here. The injections that we put into the vocal folds, if we do the 4 sites, then it's just a tiny little bit, almost as small amount that you can put in, which means in dosage, maybe 1 or 2 units of Dysport, which would be a half a unit of Botox, if you will. So the injection takes place right now. So I have to correspond and talk with the assistant and say, now I'm set, please advance the needle out, and now inject. And now the last one, the 4th injection site, is the right vocal fold, which I target with the catheter. I try to keep away from the lamina propria. I try to inject deep into the muscle, and please avoid the vocal fold itself. It wouldn't have any action, and you don't want to inject into the rhynchi space, because then you would have a hydrodissection, which wouldn't help the patient, and it would, on the contrary, actually have a bad voice as a result, as long as the fluid is inside. So the last thing is, I want to control that there's no bleeding, which means I'm asking the assistant to help me to suck out the saliva that is pooled, and I'm now observing the larynx if there's any bleeding, and this is not the case, so then the intervention is finished, and the whole intervention lasted something like 4 minutes. So let's see, if a patient does not tolerate the flexible endoscopy, what could I do then? Well, you can also approach the ventricular folds in a percutaneous approach. So this is a gentleman who actually has a pretty of gag response when I inject with a channeled endoscope. So what I'm doing is I'm having the assistant hold the flexible endoscope far away from the larynx, which means at the level of the uvula, and then I'm going at a thyrohyoid approach. And the needle is a 23 gauge needle, 60 millimeters long. And what you can see in the middle photo is that I'm pretty much steep going into the thyrohyoid space and then directing the needle pretty much downwards, but I try to avoid going intraluminal. So what I can do, if it works, then I can wiggle the needle and then do the injection into the left ventricular fold. And let me play that again at the very beginning. Look at this anterior part of the left ventricular fold. You can see the wiggling of the needle. When I see that the position is inside, then I can inject whatever dose I think is appropriate. So you don't have to enter the lumen of the larynx. What is the advantage of this approach? If you don't go transluminal, then the patient has less of a gag response, because what triggers the gag response is the nerves in the mucosa. So if you stay underneath the mucosa, then it's easier. And then you can do the same injection on the other side. So you retract the needle, not all the way out, but halfway. Then you direct the needle tip to the right side and then go into the right ventricular fold and then inject the amount. It's also very helpful. And for this, you don't need a channeled endoscope, which is an advantage in some clinics. Other alternatives that we have, of course, we can put the botulinum toxin in general anesthesia if you want, and you can put it into the ventricular folds or vocal folds, as we know. But there's also the transoral indirect approach, which is in the lower left, and then you can inject into the ventricular folds, of course, and see where you're going with a needle. Some patients like that even more. But what you can't do from the cricothyroid, so from the lower approach, you cannot cross through the glottic area and then go from beneath into the ventricular folds, because the way is just too long. Maybe you could do that with a long needle, but I would say this is a very, let's say, cumbersome and awkward way to reach the ventricular folds. So how about the complications? Well, the complications is, as in any injections of botulinum toxins, we know that they're rare. But as soon as you put in the botulinum toxin, it stays there for the next 3 months. There's no antidote against that. We have seen no serious complications actually in either approach, into the vocal folds or the ventricular folds. And of course, always when we do interventions in the larynx, whatever, excisions, biopsies, injections, then you can have vasovagal or laryngospasm, and also in the nose, some epistaxis. And of course, let's say if you dose very high, then the botulinum toxin can lead to too much of an paralysis or paresis of the muscles and then lead to aspiration. We haven't seen that, let's say, in a severe case, but in a slight way. Then, of course, you can and you have to tell the patients what to do as an avoidance strategy, which we know from dysphagia therapy in patients who have a unilateral vocal fold paralysis. So, but overall, I must say this is a rare complications that we've seen, and it is a nice way to inject the botulinum toxin into the larynx. So, what are the advantages of this method? Well, we know that botulinum toxin already is a gold standard for the injections. And the injections into the ventricular folds is an easy technique, as I've shown you, and it avoids the breathy voice, and that's what the patients really like. But if you think that because of the severity of the clinics that the patients need more, then you can also put a small dose into 1 or 2 vocal folds. The other thing is that also there is a help and a chance that if you have a patient with spasmodic dysphonia and they have a tremor, that this also reduces the tremor quite some bit. I can't tell why this happens, but it's just a clinical observation that if you inject into the ventricular folds, sometimes the tremor goes down. And for our patients, many of those patients who don't like the percutaneous approach, they don't like the approach transoral direct in microlaryngoscopy or indirect, they really favor this. It's a quick procedure, and some patients even say, I couldn't feel anything, and it's not, associated with big pain. Actually, it's just a tiny little prick. However, there's, with every technique, some disadvantages that have to be mentioned. Number one, you need equipment for the channeled endoscope, of course, which is the invest that you have to do. You need an assistance for an injection, so it's very difficult to do this alone. So you need somebody else. Could be a nurse, could be a second doctor, of course. We don't have EMG guidance with this because there's no device for the laryngeal EMG for that transnasal approach. And of course, as in any injection of the botulinum toxin, you have to be aware of the dosage and do not overdose. Now, sometimes there's a question, is it enough if I put the botulinum toxin just submucosal, or do I have to go deep into the muscle or more in the posterior or anterior part of the ventricular folds? I think we still don't have enough data to say something about that. That is a robust data on long-term outcome. But if you would ask me where I would tend to put the injections, then I would say more anterior to the bulge of the ventricular fold, stay away from the posterior part, and I would try to go in something like 4 or 5 millimeters, not only submucosal, but a little bit deeper in the ventricular fold. So overall, one can say that as a conclusion, your patients will like it, and I hope if you have the chance to try it, why don't you broaden your armamentarium of the treatment in patients with spasmodic dysphonia. Thank you very much.
Thank you very much. Now we're going to proceed to Q&A for 5 minutes, please.
Hello. Hope you can hear me.
Absolutely loud and clear. Thank you, Dr. Hess. The first question here is that can ventricular fold injection be done transcutaneously, EMG guided, rather than endoscope guided?
Yes, of course it can be, as I showed and tried to show when you go thyrohyoid from up here. The question is, EMG needs muscles, electromyography. And we also did a study, and one of our doctoral students, Feline Albrecht, looked at muscles in the ventricle or in the ventricular fold, and she found, it's not published right now, that only in 60% of all the patients that she looked at, of the larynges, she found muscles, which means if you have no signal, no EMG signal, it could still be that you're right smack in the right spot, in the hot spot of the ventricular fold, and then you can inject it.
Right. I do hope that this question was not, can you skip the endoscope and do it basically just by EMG guidance, is it?
You know, the EMG needs a muscle and it needs a biosignal so that you know where the tip of the needle is. And that is true for all the muscles of the larynx, but it's not true for the ventricle. So I would say in this case, you need the optical monitoring, which means you need to have some kind of laryngoscopy. It could be rigid, of course, it could be flexible through the nose. Yeah. But I think with EMG alone, yeah, you're not so sure. But I have to say that I know there are colleagues out there who do even the injections into the vocal fold without EMG because they've done it hundreds of times, you know, from cricothyroid, and they go spot on into the vocal fold. So EMG is not always a must, but it's a helper. And for the beginners, I would say it would be recommended percutaneous. If you do it through the nose, then you don't need it.
Is the effect of the Botox basically visible or hearable in real time, or is it has it some delay?
It has a delay of 1 to 2 days. That's what we know from botulinum toxin injections. However, sometimes if you have a kind of a manipulation of the system, it could also be from outside. So if you do something to this area, then you can have an effect that is immediate. And this is not a fake. It is called geste antagoniste, and we know that from patients with spasmodic dysphonia. When they do something, manipulation on their chin or in their neck, then they can reduce the spasmodic component, mostly in the adductor type. So